Okay, good afternoon to all. I'm going to introduce myself. My name is Paula Gomez. I'm working for Learning Solutions and Training Team in Lyon. We are part of the WHA World Health Emergencies Program. And I'm going to give the floor now to the unit lead for our unit. My supervisor's name is, Philippe Gasquet. So yes, it's to you, Philippe, to start with the presentation.
Thank you, Paola, and welcome to everybody. We're absolutely thrilled to have so many people from literally around the globe to participate in the webinar this afternoon. I mean, for us, sorry. Good morning for those of you still in the early morning areas, and good evening to those who are, where the sun is setting at this stage. And not counting our colleagues also who are on the Southern Hemisphere as well. So this is very nice to see you again. For some of you, I believe that you've been with us on this journey from the first webinar, and we are now entering the fourth webinar already, end of October. It's amazing how time flies. And the fourth webinar into the series of webinars for on COVID-19 for National Rapid Response Teams virtual learning series. So for those of you who may not have been around before, just a quick review that really here we're focusing on the needs for National Rapid Response Teams at national and subnational levels. So our purpose is really not to drill or to deep dive into any of the subjects that we are presenting, but more to make a link in terms of what is the topic area and the roles and responsibilities of the rapid response teams in this context. And so we hope that in doing so, we assist in reinforcing the learning needs of national rapid response teams based on the challenges that you may have experienced in or encountered in responding to COVID-19 in the past 6-7 months. And bearing in mind that this will remain with us for a solid 6, perhaps months, perhaps 12 months, at least until a vaccine has been provided and vaccine campaigns can be successfully implemented. So we are in this pandemic for a long time, and the role of rapid response teams, which typically are focused on in other epidemics on the first 24, 72 hours of an outbreak, takes a very different approach here. And so this is why it's important, we thought, to help out the rapid response teams in 3 different ways, in learning in 3 different ways. One is to acquire the basic knowledge, and there I'm going to refer back to this learning package that we have developed and made available for individuals on our learning platform. And this learning package has about 11 different modules that you can review on your own time to go more in depth about some of the aspects. And we'll take you also to the guidance documents that have been developed by WHO, etc. Now, in these webinars, it's about building a little bit more in-depth knowledge about specific topics and to see how to apply the knowledge in various contexts, but also to start the process of sharing of experiences, based on the situations that you've gone through in the past 6 months. And then the third step in this is the peer-to-peer learning that we want to facilitate through a sharing of practices and by the way of our knowledge network for rapid response teams. So several of you are already member of this network. We have actually 2, let's say, tracks on the network. One is the Francophone track and the other one is the Anglophone track. But most of them, most participants are in the Anglophone tracks, and there is a lot of exchange on various aspects of COVID-19. And we currently have an analysis of the knowledge that has been captured from these exchanges in terms of, you know, what have we learned from your experience in the field in dealing with the COVID-19, and we will share that the findings with you on the Rapid Response Team Knowledge Network. So just a quick overview of the 4 webinars. If we can go back one slide, of the process that we went through. So like I indicated, it's the 4th webinar that we're dealing with today, data management and disseminations. And initially at the very beginning, we indicated that, you know, we might have, we might consider designing a couple or proposing a couple of other webinars in November. And we've taken a survey with some of you from the very beginning and then refined this survey with the 3rd webinar. And here we wanted to share with you the results. So we've tried to take into account the feedback that you gave us and also the availability of various subject matter experts, because the participation of the subject matter experts is absolutely key and their contribution. So we cannot do that without them. And so what we think to offer at this point, apologies here, and we still miss a couple of we still miss, we need to consolidate, sorry, the arrangements with the subject matter experts in these areas. But we're considering 2 themes at this point. One will be cross-border collaboration for efficient control of COVID-19 pandemic and how national rapid response teams can plug in there. And so we will discuss with our colleagues in that area. And the second topic is rapid response teams management in the context of COVID-19, but being understood as a very broad concept. And very importantly, I think there is a theme that we need to address here, which is like in a long lasting pandemic. So it's not like a quick, short action, but it's the role of rapid response teams and management over a long period of time. At the same time, we are considering addressing issues such as dealing with other public health issues. Typically, a rapid response team can be deployed for cholera, for traffic accidents. We've been exposed to this. To not Ebola, I mean, and it's ongoing in the Democratic Republic of Congo at the present time, number of issues. And so, you know, what happens in these different areas and what's the role of and responsibilities of the rapid response teams in balancing all these various agendas? So, and another aspect that we will deal with in this webinar will be to see the collaboration with emergency medical teams, hopefully. So we will get back to you in terms of how we organize this, but potentially the dates for this would be Tuesday 17 and Tuesday 24 November, and we will come back to you in terms of the exact arrangements for these webinars. Next. So the key learning points that were from the previous webinar, number 3, are on occupational health and safety. We had very interesting discussions here. And we know that the health and safety of rapid response team members are key to their performance in the context of COVID-19. So they have to be assessed, these needs, before, during, and after the deployment of the rapid response team. Rapid health and safety of rapid response teams members may be at risk at any time during the deployment. And it's not only the epidemic, of course, as we know, the pandemic and being exposed to the virus, but it's also dealing with the communities, dealing with individuals, daily monitoring of preventive measures and protecting, you know, the safety of responders, and also maintaining some kind of team spirit and motivation. It's very important. I mean, this is why we talk about a rapid response team. An application of protective measures is a top priority during COVID-19, and we hear every day, and I'm sure in every single country where you work in, you have stories about people in the health areas being exposed due to poor protective measures, lack of access to protective measures and things like this. So that was a quick summary of the learning points, but of course, if you want to have more on this, you can also listen in to the registration that was made of of the previous session. So these sessions were all recorded, and the recordings are available to you, as well as review the module on occupational health and safety, which is part of the package of 11 modules that I mentioned earlier at the beginning of my intervention. And I believe this is it from me at this point. I'd like to thank you very much. Again, like I mentioned, we cannot do these webinars without the contributions of subject matter experts. And more specifically for this webinar here, the very strong contribution of the EMRO team that has prepared this webinar, and with the added input from our colleague from AFRO, who is going to be sole-handedly guiding us tomorrow in the Francophone session. Thanks, and over to you, Paul.
Thanks so much, Philippe, for this introduction. I'm now going to remind everybody briefly about the Rapid Response Team Knowledge Network that Philippe mentioned just earlier. So, yes, some of you may already be part of the Rapid Response Team Knowledge Network, which is a community of practice that gathers participants of national rapid response teams who have been trained for most of them by WHO over the past 5 years in various countries in the African region and in the Eastern Mediterranean region as well. This community, its aim is to keep an opportunity for continued discussion, sharing of experiences, sharing of good practices, having access to peer-to-peer support by throwing questions to the network that can be responded by other members. And it's a good resource for keeping up to date on what is happening in terms of outbreak response and other issues that are relevant to rapid response teams. So at the end of the webinar, we will provide you with the registration link if at all you have not yet joined. And actually, you see that the webinars are related to the knowledge network in the sense that we start the discussion here during the webinars in specific topics based on the questions that you have highlighted that you would like to see addressed. And these 2 hours don't enable us to go into the details of all the topics that you would like to see addressed, but the Rapid Response Team Knowledge Network offers an opportunity for continuing this discussion after the webinar has ended up. So we strongly encourage you all to join. And quickly, I'm going to go through these house rules that will enable us to work smoothly together during these 2 hours. So we kindly ask you to keep your microphone muted, disable your camera. Yes, introduce yourself on the chat box, which many of you have already done. So please keep also your smartphone ready for participation to the webinar activities. And also you are invited to use the chat box for asking questions, requesting some clarifications, contributing with your experiences, but also feel free also to respond to other participant questions if you feel that you have. Yes. Please, can you keep your microphone muted? Thank you very much. So you can also respond to other participant questions because the expertise is everywhere here, and you may have an experience that will help, assist, and highlight another participant who is requesting, asking a question or requesting assistance. So, okay. So here we are going to, as we have done it for the previous sessions, we are going to have a short activity with Slido. that I guess most of you already know. This application that enables us to respond to questions during the webinar. So you are all invited now to scan the QR code that you can see on the screen, or to type in your browser slido.com, and the password is RRT2. Silvio, it's to you now.
Yes, hello everybody. My name is Silvio Mena. I'm also a member of the training team based in Lyon. So I will open the icebreaker exercise right now. And I think you should be able to see that very soon on your phone. So as Paula just said, and I repeat that, you can scan the QR code, or you can also type on your browser, on your mobile phone, if it's possible, slido.com, and then RRT2.
So the evolution of learning, this is something that we have mentioned at the end of each webinar, as you may remember. So we want to have those who are interested in taking the evaluation will be sent with the link to the evaluation will be sent by email to all those who have participated, and those who are interested in taking it can take it. And the evaluation will cover really the content of the 4 different webinars that we have conducted. So we have 69 people who responded. So as a reminder, you can either use the QR code or type in your browser slido.com with RRT2 as the password. So we have 145 people.
So currently we have 86 people who replied yes to this question. So we'll do that very, very soon.
Yes, and if you don't have the capacity to respond in Slido for any reason, you can also respond on the chat box. Okay, so probably when we reach the 90, we can.
Yes, here we are. Anyway, you will have some more time to do that. I mean, after this, when I will stop sharing my screen. So please do it. It helps us understand what. Yeah. Anyway, we'll see the trend. It's a clear trend. So, Paula, are you ready?
Yes, thank you.
Okay. I stop sharing my screen.
So thanks so much for responding, and we are now going to enter into the hard content. Okay. So as it was mentioned by Philippe earlier, this webinar has been prepared by a team composed of colleagues from the Richard Regional Office for Eastern Mediterranean, and from the Richard Office for the Regional Office for Africa. And some of them will be facilitating today and some will not. But you have to know that it's a group of experts that was involved in developing the content of this webinar. So without further elaboration, I'm going to pass the floor to Dr. Shireen El Nasri for the beginning of the presentation. Dr. Shireen?
Okay, thank you, Paula. Good morning, good afternoon, good evening, according to the way where you are. My name is Shireen Nosiri. I'm a medical epidemiologist working in EMRO. By the ending of this webinar, you will be able to identify effective process for data collection, analysis, and dissemination in context of COVID. Use and adapt relevant up-to-date tools for data management, and to identify key challenges in data management and dissemination and their solutions in context of COVID. Next, please. Okay, we'll start with some definitions. What do we mean by database management system? It is a system to organize and manage large amounts of data. What do we mean by data management? It is the practice of collecting, keeping, and using data securely and efficiently and cost-effective. The goal of data management is to optimize the use of data within the bounds of policy and regulation so they can be used for decision-making and taking actions. Next, please, Paula. First, you need to identify the objectives of data management, why we need to do data management. And here we are focusing on COVID. So we do data management to monitor the disease transmission, to monitor the impact of prevention and control measures, to describe the event in a proper and useful way that help in the decision-making who needs this information to take decisions, to monitor all contexts, and make sure that they are followed for 14 days in order to identify early COVID symptomatic cases for early management, monitor daily magnitude of the outbreak or pandemic, see who's affected in terms of person, their age group, their sex, if they are healthcare workers or not, and time and place of the outbreak, to monitor the procurement and supplies management in order to avoid stock out, and to use the daily analysis as evidence to take timely required actions for the control of outbreaks. Next, Paula, please. Data management is an ongoing task, especially in outbreak investigation. It should start with data collection. We need to identify the data collecting tool that will be used, how we will compile these data, how we will enter, and we normally enter using appropriate software, how we will clean it, how we will analyze these data using different graphs and tables, what are the analytical tests that we can use, and the most important thing, how to interpret this data, how to give the meaning for the beautiful graphs and chart that we create in order to help taking actions. It is data for action. We need to make sure that what we produce can be interpreted and can be used for decision makers. And as it is a cycle, we need to evaluate and then recollect more data and information. Next, Paula. So what are the data sources? It could be either primary or secondary. Primary sources can be health surveillance system, data from health records, surveys, household surveys, or field data during case investigation and contact tracing, for example, and also lab data. Secondary source data can be obtained from population census. Next, please, Paula. Over to you for this slide.
Shireen, now Sylvia, it's to you for the Slido questions.
Yes, I hope you can see my screen. So now you can. answer the 2 or 3 questions. I think we have 3 questions in this one first. So true or false, errors could be originated during the data collection process.
Again, you can use your smartphone to scan the QR code or type slido.com and RRT2 as password for the in your browser if you cannot scan the QR code to respond to the questions.
Okay, people are quite fast. I see that we have already 70 people who replied.
Well done.
And maybe we can see the second one then, because the 3 questions, maybe I need to just do it as well.
Yes.
Okay, let's go to the next one.
Yes.
Next questions.
Probably we can hear from Shireen in terms of what she thinks about these responses. Shireen, what do you think about what has been answered?
Yes, it is true. Data error can be generated during data collection. It can be in the form of missing data or duplicated data. We might enter the answer in a wrong box or leave some boxes blank. If there is many options, sometimes it is we select. We don't select many options. We select only one option, and on the other hand, if we are supposed to select only one option, sometimes we make it like a multiple. Sometimes it is just spelling mistakes, and it's right, as you said, it can occur in data collection. Over to you, Paula.
So now you can see also the result for the second questions. True or false, errors could be originated during the data entry process. So we have 97% true. And 94 people replied. So maybe Shireen, you can tell us more about it.
Thank you, Salvio. And again, yes, data error can be generated during data entry. All of us have this situation when we go to the field and collect many data, and then when we go back to the office and try to enter it using different software, sometimes we miss some data, sometimes we left some places empty, sometimes we duplicate during the data entry. So yes, it could happen during data entry. Over to you, Salvio.
Okay, let's see the last one. So true or false, errors could be originated during data processing and analysis. So now we have a kind of, we have other answers. I mean, about 18% false and of course 82% true. I'll let you comment these questions, Shireen.
Okay, yes, that error can occur during processing and analysis. Okay, sometimes we enter a wrong code for the data, for example. Sometimes error occurred in data extraction and transfer from one software to another. By mistake, we might delete or duplicate during the analysis. Outliers occur, sometimes it occurs in the processing and analysis. So as you can see that errors could occur at all stages of data management, either data collection, entry, or processing and analysis.
Okay.
Thank you, Salvio.
So we have a last question for this part, which is what are the possible sources of data errors? And you can write your answer and we will see that as a cloud word. We'll give you a few minutes for that. Okay.
So we see people also who are responding through the chat box. And you see also human errors. What do we see again? Okay, for the time being, only that one for this question. So
it seems that human is the problem.
So Shireen, if you would like to comment, and probably at the same time, you could comment on a question that has been just raised in the chat box. So in each stage, how can we reduce such errors?
Okay, thank you, Paula, and thank you, group. It is amazing. You are great. Actually, you covered all the errors that could occur during data management. And as you said, it might be human error, typo, missing data, miscommunication, missing information, untrained staff. Yeah, of course, training is very important in order to avoid these kind of errors. Spelling mistakes, selection bias, data entry. Okay, great. And the question is about how to avoid this. It is the focus of this presentation. We will try to provide you with some solutions, and if this will not be answered properly in the presentation, you can raise this question again. Paula? Okay, here is a summary of the sources of data errors, and as we said that it can occur at any stage, either due to on data collection or data entry, or in processing and analysis. We already covered this. Next, Paula. Okay. So the first solution in order to avoid these errors is to develop a data dictionary. Data dictionary is a detailed dictionary with variable names, variable description and labels, and variable types, and response option. For example, if I'm going to enter male, the sex, so the variable name is the sex label. Okay, it is description. The type, it could be male and female. So I might enter M for male and F for female. So the first option to develop a data dictionary. Next slide, please, Paula.
But it's okay when he approves, then send it with the right.
In data cleaning, okay, when data is entered on the software, we need first to screen it, to have a look on it and try to identify the outliers, missing variables. What are the strange patterns in order to correct it, diagnose what happened. For example, if this outlier, if we enter for the age, for example, it is 100. So it is an outlier or extremities. It is true or false. We need to think first about it, if it's true or false. And then we need to treat this error either by correcting it or deleting it or leave it unchanged. But whatever the change I do, I need to document it. Next, Paolo. Here we have another group work. Have a look, try to screen this data set and identify different errors. Over to you, Paula, to guide participants for this activity.
Thank you, Shireen. Yes, so here you have this database with some errors inside, and the idea for this activity is for you to identify where the errors are found, and then you can write them down in the chat box. You can either identify them using the letters and numbers you see as reference for the rows and the columns, and we will have a look on your responses and provide you with some feedback afterwards. So I see that already participants have started responding. Okay. So take your time. There are quite a number of errors in the table. So let us hope that you will identify them all. Excellent. The questions, the responses come very quickly, and we see a lot of the errors already identified here. Okay. Excellent. Okay, so Shireen, probably we could have a look at the responses and see how participants have done so far.
Yes, that's great. Excellent work. We can screen, first we need to screen the data set. We can screen it either by looking vertically or horizontally by the row or the column. If we start by record number, for example, here we can find 1,322. It is an odd number and we have 14. So there is something here is not okay, the record number. The age, as you said, we have 200 and we have 101. So we need to review this and try to correct. And as you correctly mentioned that we have here male and pregnant. So we need to check this again. Also, we have some blank fields, for example, symptomatic. There is nothing here. So we need to check from the field worker who collect from the data collector. We might go back to them and try our best to verify this mistakes or missing parts. And as many of you said that a date of confirmation for some cases is before the date of reporting, and which can't be right. So yes, as you said, and great work, excellent work. These are the type of errors that we can find in during data entry. Maybe we need to move to the next slide. Yes, here we highlighted the different errors. And as you said, that it is, as you mentioned. Next slide, please, Pablo. Thank you. So investigation generate large volume of data about cases, contacts, the lab data, and we need to organize it in a way that minimize human error. There are several tools, softwares that can be used for data management, like Microsoft Excel, Access, EPInfo, EPIData, SAS Data, SPSS. Some specific programs like the eWarn for surveillance outbreak platform and GoData, which was used during Ebola and COVID outbreaks. But we need to consider many things in choosing these tools, like the data entry. Is it easy to use it for data entry? Can we minimize the human error or not? For example, the Excel, it doesn't control the data entry. There is no limit for age, for example. There is no codes. Not like the EPInfo and the SPSS, when I can put some codes, some rules that eliminate the human error. Second issue, does this program can produce basic and advanced data analysis or not? Its cost, graphics capabilities, can they produce good graphics, charts, and so on? The speed of the network, sometimes when we gather more than 1,000 or 100,000 records, sometimes the data, the software can have problem in doing the analysis. So its ability and the speed of the network should be considered. Can we modify it or not? The ability of modification is an issue also. The skills of the employee, because some of them need training, as you said in the chat, so they need training. So the ability of the employee and the user support. For example, some of these tools have like user guide. There's videos on YouTube that tell you how to do this, how to do the analysis. So all of these factors need to be considered. Next, please, Paolo.
Yes, I will pass to the next, but I just want to inform or remind to participants that we are going to have a set of 6 more slides with Shireen now, and then we will take some time to respond to questions that relate to this part of the presentation. So if you have any questions as Shireen is presenting, please write them down in the chat box, then we will take a few minutes to address them after this set of slides. Thank you.
Thank you, Paula. The third solution to avoid errors is to have a plan, to plan well for the data management and data analysis. Like first to check the data quality, to compile the data from different sources, describe the case distribution, and calculate rate, ratios, and proportion, and think about how to present the results in tables and graphs. If I'm planning to do advanced data analysis, I should plan to compare with the expected, what is expected, compare with the references, or compare to the same period during the same month in the previous years, for example. Use statistical probability, identify subgroups, and identify potential risk factors. I also need to make sure that I can interpret the results, and it is part of the analysis plan. Next, Paolo, please. Okay, based on the type of the data, either qualitative or quantitative, I will choose the statistics or the test that I will use. For example, the qualitative categorical data, which is like the country, the district, diseased, yes or no, we use the proportion and rates to describe it. While if I'm using a qualitative continuous data like the age, the height, something that can be measured, I use the measures of center, location, and spread to analyze it. Next, Paula, please. To describe the outbreak, we have 3 steps to do the descriptive analysis. We count first, number of cases, number of contexts, then divide in order to calculate proportion rate and compare. And when I talk about descriptive epidemiology, I should think about person, place, and time. I should categorize the data according to the person, like age, sex, occupation, place, the geographic location of this outbreak, and time, which can be described by epicurve. Next.
Sorry, colleagues, I believe there is someone who has the mic open, unless it's the noise coming, if the noise is coming from your office, Shireen, I'm not sure. So let's try to have the mics muted so that we can follow the presentation. Thank you.
Okay, thank you, Paula. Yes. So the first step is count. Okay, it is a common descriptive measure. It is the first step in calculating rates, and it is essential for service delivery and planning. For example, I count number of attendees or number of beneficiaries from this service, number of vaccinated children, and so on. Next, Paula, please. Using the measure of central location, it's a single measure that represents the entire distribution of the cases, like mode, median, and mean. Mode means that the most common value, mean is the central value, and the mean is the average. Mean is suitable for all kinds of data, and so sensitive for the outliers. So it has the best statistical properties, but it should be used for just normally distributed data. If the data is not normally distributed or skewed, it is preferred to use mean instead. Next, Paula, please. Third step is to divide by calculating ratio, proportion, and rates. What is the difference between the 3 of them? Is the numerator and denominator. If the numerator not related to the denominator, it is ratio, like ratio for male to female ratio. Proportion if the numerator is part of the denominator, and the rate if I'm including the time factor. Next, please, Paula. Then the data presentation. There is a different options like graphs, charts, pie chart, bar, histogram, maps, and it depends according to the type of data, either qualitative or quantitative. But the most important of them is to be self-explanatory, to be informative. I don't need to present something complicated that I need to explain. People should have the same conclusion when they see this graph. For person, it could be presented in pie, like male to female ratio, on bar for the age distribution, or the population pyramid, also for age distribution. Time, it is better to be represented in an epicurve, which is used for outbreak investigation, and the epicurve can give me idea about the nature of this outbreak. Is it caused by common source, or if it's transmitted from one person to person, or the cause is intermittent. Place is described by using maps or simply by using tables. I believe I finished my part here. And please, colleagues, if you have any question, you can put it in the chat and I am happy to answer it.
Many thanks,
Over to you.
Many thanks, Shireen, for addressing these points. So I believe there are already some questions here in the chat box. So there was one about Go data. I saw a response in the chat box, but probably we can further explain to the group what is Go data in a few words so that everybody hears the same at the same time.
Yes, Paula. Go data is a software developed by WHO. It is used for entering data about cases and contexts. It has different features, but the most prominent, most useful feature is that can generate a transmission cycle. We can know which case transmitted the infection to what contact. It is useful for contact tracing. I think maybe I will share with you some references in the chat box if you need to go through it for more details. And also in Open WHO, there is a beautiful presentation and sessions for Go data. Over to you, Paula.
Excellent, excellent, thank you. So I don't know whether you have access, Shireen, to the chat box. A few questions that are posted here. Could you please explain how to handle the big data entry and analysis? This is one of them.
Yeah, it could be handled by softwares, but as we said, if we're talking about simple tool, we can use Excel, or we can use APInfo, or we can use Go data. It can help in this matter.
Okay. And then another question is more related to EMER countries. So for COVID-19, which data platforms or software are used by most EMER countries? So this is a question about the region and the countries.
Yes. Yep. Okay, so give me some time and I will give my answer at the end of this session, okay, about the most used software in our region.
Okay, no problem. So let's keep that for the end. And then there is a response here that has been provided by one of the participants about big data. So this participant suggests that for big data, there are SAS, Python, Stata, SPSS that can be used. These are some of the suggestions.
Yeah, thank you, Suhail, for this suggestion. But again, we should consider the cost because most of them are, you need to purchase it. Okay, so if you don't have the permission to use it, it might be an issue. And also for big data, of course, there is a limit. For each data, there is a limit for its capacity. Another issue we need to consider using SAS and SPSS is the capacity and skills of employee. If they are trained on using this, it will be great. Thanks. Over to you, Paula.
Thank you. So we have other questions such as, is Go data freely available for everyone to use?
Yes, just contact the country office or contact us, and we will support using GoData.
So the WHO country office, or you can send email to you putting your email in the chat box and adding your name, and we can guide you through the process for accessing it. So we have other questions here or other suggestions. So yes, somebody added that not the issue is not only the subscription, but also some level of training to use those softwares. Yes, so I don't know if you are hearing me, Shireen, or other colleagues present in the webinar. What can we say
yes,
about?
Paula, can you
Yes,
repeat the question?
I was saying that it's not somebody is suggesting it's not just a matter of subscription, but also some level of training that is needed to use those softwares.
Yes, sure, it is true. As we said, that we need to consider many factors in choosing the used software, not just the cost, the level of training, and how it can produce graphs and the easy to use. All of these factors should be considered in choosing the appropriate software. Over to you, Paulo.
What else do we have? Okay, yes, the presentations will be shared after the webinar with everybody. I don't know, colleagues, if you see other questions that still need to be commented or addressed. So many people, I see that many people are interested in knowing more about GoData. So we will, if you provide your name and your email, we can get back to you after the training with more information. I don't see any other technical question at this point, unless I am missing. So if there are no additional questions right now, we can move to the next topic, and then there will be additional time for questions at a later stage. So I will now pass the floor to Dr. Mohamed Tahoun for the next step of the presentation. Dr. Tahoun?
Yes, good afternoon and good morning and good evening, colleagues. This is Mohamed Tahoun. I am a medical epidemiologist working in the Health Emergency Information and Risk Assessment Unit within the WHO Health Emergency Program at the Eastern Mediterranean Regional Office. Before I begin, I just want to point out to respond to one of the questions about which software to be used. Just some of the important products, okay, that could be produced from the analysis is these AP curves, okay, and these, for example, could be easily produced through the using of Excel. Of course, whatever the program that's being used, it needs some training, okay, to be able to generate such analysis. But there are not sophisticated programs and not programs that require subscription or fees or something like this is the only ones that are needed for producing the analysis or effective analysis. Okay, so for the next couple of minutes, I'm going to talk about the indicators that could be produced during the contact tracing process and from the surveillance process, and about the whole data management. And then we are going to talk about the criteria of good indicators, some of the indicators that we usually use during the outbreak, and then we will end by some of the ethical considerations and the challenges that we may face during the data management process. So as a beginning, what are the indicators? Okay, so we are talking about in a very simple way that these are variables that we use to measure the change we want to achieve through a specific program. So we have detected or we have experiencing a COVID-19 outbreak. So there are some, there should be a response, and to monitor this response and evaluate the activities, there should be some indicators. So the scientific definition of indicators is that these are some specific, observable, and measurable characteristics used to show the changes or the progress towards the achieving the specific outcome of the programs. How many indicators and how to select indicators? Simply, there is no ideal indicator to be used. However, we are going to talk about some of the important indicators that's going to be, that of course reflect or measure some characteristic of the epidemic. Regarding the selection of the indicators, it should measure an important outcome of the public health activity or the work that's conducted, and use a standardized measures, not to be measured differently across different regions or districts or national or international level. And also another important criteria is that there should be followed by an action. So what is the value of indicator? If there is no action that could be taken to improve this, to improve the outcome. And of course, it should be reported from most sites, okay, where I'm going to collect these indicators from, and it could be measurable over time and easily understandable. In the next slide, we are going to have an exercise. So please, Paula.
So here you can use again your smartphones to connect to Slido, and we have quite some time ahead of us, so we can give the chance to everybody to the majority of people at least to connect and respond. So the question is now the criteria of good indicators. What do you think the criteria of good indicators should be? Okay, so we have 75, 76 people who were able to vote, and it's coming very, very quickly. Okay.
So we have many interesting answers. The main one is SMART, so S-M-A-R-T. I think most of you, yeah, we see specific, measurable, achievable, realistic, and time bound.
So, Mohammed, what do you think that about the answers that we can see so far?
Yes, yes. Actually, I can see that they are very interesting. Okay, and more or less they covered all what's going to be said. I can see that they are talking about the SMART criteria being measurable, specific, and valid, okay, time bound, achievable, result oriented, timeliness, which is like time bound. Let's go to the next slide and see what are the criteria. Okay, for these are the top criteria, okay, that we are looking criteria for good indicators. So first of all, it should be valid. Okay, so what's meant by valid? It means that it truly could measure the outcome that I want to assess, and then followed by reliable, which is being consistently measurable by the same way by different observers. And regarding being precise or specific, this, as we will see later on, it should have a very clear terms and use, okay, case definition, okay. So as we will see that there we have some indicators that are calculated using the numerators and the denominators. So each indicator should be clear in what is the numerator and what is that denominator. This is for, of course, the quantitative indicators. Then being measurable, which is already have been said, which means that it's quantifiable using the available tools and methods, and which these tools and methods should be accessible and available. Okay, not being hard to reach or expensive or something like this. And of course, being timely or time bound, because okay, what is important? Well, it's important that each program is planned across a timeline or a schedule, okay, that we should track the activities that's done and the changes that should be achieved during over different periods. And finally, of course, to be programmatically important. And this, of course, should be related to the objectives of the program implement. Okay, I could see that there is a question in the chat box about the contact tracing indicators, and we are going to talk about them in a few minutes. Among the most important indicators that we are using in the current COVID-19 epidemic, or even in any outbreak of disease, is the mortality indicators, the morbidity indicators, and contact tracing indicators. Next. So regarding the morbidity indicators, we have several morbidity indicators. We have the prevalence, which is also considered as a proportion, which is a snapshot, okay, of the situation of the disease within a certain point of time. So it's calculated as number of people with the disease at a point of time divided by the total population at that time. There is also cumulative incidence, which is considered as a proportion, also known as the risk, or when we are talking about an outbreak or epidemic as we are, it's also termed as an attack rate, which is coming later on, which is calculated by number of new cases within a specified period among certain population divided by the total number of people at risk in the study population. There is also another proportion or another indicator, which is the incidence rate, which takes into account the time. Okay, and this is usually calculated in the prospective studies because, as you know, in the follow-up studies or the prospective studies, not all the people remain in the study for the certain period of time. So it takes into account the duration that each individual stays in or remains within the study. But the numerator is the same, which is the number of new cases of a certain disease, but it's divided by the total or the sum of the time that each individual remained within the study. Regarding the attack rate, as I mentioned just a few seconds ago, that it's calculated the same as the incidence, which is the number of cases of a disease during a specific period divided by the total number of people at risk. This is regarding the attack rate. So there are two examples, as we can see, that there are 75 people at a picnic and 46 got sick within several hours. So simply to calculate the attack rate, it's about it's 46 divided by 75, which gives 61%. Another example is number of cases of hepatitis A in districts A and B is 25, and the people at risk from both districts is 600. So the attack rate per 1,000 population, this is another method of calculation, is 25 divided by the 600, which gives 41.7 per 1,000 population. Next slide. So another indicators are used is the accrued mortality rate, which is the accrued ratio, the number of deaths, okay, the total number of deaths among certain population divided by the total number of population during the same time period. And this is very crude, as I mentioned. Okay, it is not a specific, and it just gives an indication about just a general figure. Okay, which we usually very fewly use it. As I mentioned, it's just general mortality indicator. The other one is the under 5 mortality rate and the maternal mortality rate. Both are used as a measures for the stage of development in countries, and this is as you could see, it's calculated as the number of deaths among under 5 during a certain period divided by the total number of population under 5 during the same time period. Okay. The unit here for the calculation of these rates is calculated as per unit time or per unit population. Okay, so we can we simply define a constant to be multiplied by these death rates. So the death rate is calculated, for example, X number of deaths per 100,000 population or 1 million, okay, according to the population time. While during emergencies, we are talking about, okay, because this is an emergency situation, so it may be calculated per unit in per n persons and also per unit time. So as you can see, there is X number of deaths per 10,000 population per day. Other alternatives may be the number of deaths per 1,000 population per month or per year, and this is different from one disease to another. Okay, what's being used now in COVID-19 outbreak or pandemic that we are witnessing is the case fatality ratio, which is the deaths from calculated as the number of deaths due to COVID-19 divided by the total number of of cases. So, and we are currently using the CFR, this indicator, as this measures the severity of the disease. Globally, the case fatality ratio is about 2.7%. So if we can see some countries with higher figures, okay, it means either the disease's severity, or maybe if we have some explanations or if we have more information about the testing strategies and so on, there could be very low testing, or maybe related to underreporting and so on. So this indicator, as I mentioned, it reflects the severity of the disease. However, it could be affected by the testing strategy and the reporting status. Currently, the most important two indicators either that we use, attack rate, okay, which is calculated per 100,000 population, and the case fatality ratio, which is calculated as a percentage. The next slide. So, regarding the contact tracing indicators, there have been a considerable number of indicators, and this is just a summary. And I'm going to share with you the guidelines for contact tracing. We are currently using, okay, which for the first indicator, for example, it is the proportion of contacts seen, and it's calculated as the number of contacts seen divided by the total number of contacts listed to be followed up. And it could be, of course, stratified by the geographic region and the type of contact, whether it's high risk contact or low risk, and by the contact tracer themselves. This is one indicator, and of course it's used to monitor the coverage of the contact tracing activities. Another indicator is the proportion of contacts to lost to follow-up, and here there is one of the main characteristics, okay, that we were talking about, which is about the being precise, okay. So here there is a definition of about those who are lost to follow-up, which is defined as not seen for more than 2 consecutive days. So as I mentioned, this is an important characteristic, just to be precise and have a clear definition for each indicator. So, and it's calculated as the number of contacts not seen for more than or monitored for more than 2 consecutive days, divided by the total number of contacts to be followed up. Okay, and of course this is also used to identify the areas with low coverage of contact tracing, and identify maybe just to list the number, those individuals that needs close or different approaches for following up with them. One of the indicators also is the proportion of contacts who become suspect cases, and those of contacts who become confirmed cases. And this is important to track the just monitor the dynamics of the outbreak. Also, there is another indicator which is linked to the previous, which is the proportion of the new cases who were known contacts, okay, but it's calculated on a different by different numerator and denominators, which is the number of newly confirmed cases among contacts divided by the number of confirmed cases. Also, to track the performance of the contact tracing, there's another indicator, which is the time from symptom onset to case confirmation, and it's calculated by counting the number of newly confirmed cases among contacts divided by the number of newly confirmed cases. So these are the most commonly used indicators for contact tracing process, and of course, okay, there are other indicators at national level, but these are the indicators that were shared during by the guidelines from the WHO. Next, Paula.
Yes.
Yes, okay. So as we are talking about the data quality, there are 6 dimensions that should be also kept in mind during the data related to the data quality, which is related to timeliness, as the data should reflect what is happening in real time, and being valid, as I mentioned before, which is related to being reflecting what's what's truly on the field, and being accurate also, which is the same about uniqueness, okay, which is the each data entry should be unique, which means that it should there should be no duplicates within the data sets. And of course about the completeness, which is related to the proportion of the data against 100%. How, for example, we have 10,000 cases of COVID-19, then how many case reporting forms have we received? Maybe 80%, 90%, 100%, and so on. Another quality or data quality dimension, or the final one, is about consistency. Okay, are we using the same? If we are using a case reporting form, is it the same one that's shared by a reputable organization? Are the variables defined in the same way or not? So it should be consistent. If we are talking about, for example, if we are talking about the marital status, then we have 4 responses, not 5, not 6, okay, and so on. So next, Paula.
So now we reach another time for questions and answers, and actually there are many questions in the chat box.
Yes.
Yes. So Shireen is also having a look, so you can see which ones you would like to address first.
Yes, thank you, Paula. First question we have from Dr. Shamsuddin from Egypt, asking about person per year and how we calculate it. Do you like to take this question, Mohammed?
Yes, sorry, can you repeat it again? Because I was just looking into the chat box trying to locate the question.
Person year.
Person year, yes, yes, person year. Simply, okay, as I mentioned, this is calculated from the perspective or follow-up studies, mainly where we have some individuals that are supposed to be at risk of developing certain disease or certain condition. But as we all know that during this, during any follow-up study, there are some lost, or what we call it, the attrition problem, okay, because some people may decide to leave the study, some people may die, or may just stop reporting, we cannot reach them, and so on. So not each individual could be followed up for the same period of time. So instead, okay, we are using the person time as the denominator by summing the period that each individual have remained within the study. For example, if we have 10 individuals, 5 of them stayed in the study or remained in the study for 5 years, and 2 remained in the study for 3 years, and the remaining 3 stayed for 4 years. Then, at the end of the study, we are saying that about I said how many? 10. Okay, let's say that 2 of them have developed symptoms. Then the incidence rate would be 2 divided by 5 multiplied by 5, plus 2 multiplied by 3, and 3 multiplied by 4. and then it will be the figure will be or the unit will be the number and ended by person year. Is it clear?
Okay, thank you, Tahoon. There is another question about what are the indicators that we should use for contact tracing?
Okay. So I have shared with them. Okay, I could see that as I mentioned, okay, the proportion of contacts followed up, okay, or seen, the proportion of contacts lost to follow up, proportion of contacts who become suspect cases, proportion of contacts who become confirmed cases, and the proportion of new cases who were identified as contacts, and finally the time from onset of symptoms to case confirmation. These are the 6 main indicators that were mainly recommended by the WHO.
Okay, thank you, Muhammad. We have a group of questions about the case fatality rate or the case fatality ratio. And it is used during COVID. Okay, what is its indicator? What does it indicate? And is it right to use it while we don't have enough data that describe the COVID outbreak? What about asymptomatic cases? Also, we have a question specific from Yemen, okay, about the case fatality, the high case fatality rate reported in Yemen, and what does it indicate? Another question, which is better to use the crude mortality rate or case fatality rate? Over to you.
Okay, first of all, I'd like to call it case fatality ratio, not case fatality rate. And this is, we as the epidemiologists, we have this debatable discussion whether this is case fatality rate or ratio. However, case fatality ratio, this is an indicator of the severity of the diseases. And as I mentioned, it is calculated by dividing the number of deaths due to a certain disease or certain condition by the total number of cases of this disease or condition. Regarding if we can use it during an active outbreak or epidemic, yes, of course. This is one of them, one of the indicators that's used. We cannot use, or not cannot, okay, if you are talking about other mortality indicators, none of the indicators, okay, of the mortality indicators would be available or have the capability to describe the severity of a certain disease or condition like the case fatality ratio, because this is due to the nature of the numerator and the denominators. The crude death rate, this is a crude mortality ratio. It's calculated by as I mentioned, okay, counting deaths from all diseases divided by the total population within a certain period of time. So is it related to COVID? No, it will not be. And as I mentioned before, that the indicator, it should be measurable and precise and specific, okay, and reflects or related to the situation or the condition that I want to track the change about. Another which indicator is commonly used to measure mortality. Both are used, but it's as I mentioned, okay, it is related to the context of the situation. So in the current COVID-19 situation, we are using the case fatality ratio. However, okay, there is another indicator that I didn't talk about, which is the cause-specific mortality rate, which is used to compare the number of deaths divided by the number of deaths due to a certain cause, which is here in our case is the COVID-19 divided by the total number of population at risk. Okay, so this may be used to compare deaths due to different diseases or conditions, different between different districts or different geographic regions and so on. So it's dependent mainly on what we are going. For example, in this case about the cause specific, okay, we have deaths due to non-communicable diseases, we have deaths due to COVID, we have deaths due to other infectious diseases. So the decision makers, and if they want to allocate, if they are in the planning stage and they want to allocate, have a certain or a limited budget, okay, and they want to prioritize, then using the cause-specific death rate in this case or in this situation might be of great value. So if we are trying to prioritize which health problem needs more money to be allocated on the next period. Regarding the question about Yemen, yes, of course. Okay, this is one of, let's say, the limitations or not the limitations, but these are one of the factors that affected the case fatality ratio. It is greatly affected by the underreporting. Okay, so and also in the case of COVID-19, it's related to the testing strategy. So if you are doing a lot of tests, then we are identifying more cases, and then there will be dilution of the denominator and a resulting decrease in the case fatality ratio. And on the contrary, if we are limiting or just keeping the testing strategy to a certain individuals, or for example, okay, in the moderate or severe cases, and then the number of reported cases will be low, and with a considerable high number of deaths, which is due to, of course, the clinical situation, and that these cases are already severe ones. This will be definitely reflected on the case fatality ratio. So as I mentioned, it's indicator of reflecting the severity of the disease. However, in the context of the COVID-19, it should be interpreted carefully, keep the underreporting and the testing strategy as well. Over to you.
Okay, well, if it's needed, we still have a few minutes for addressing a couple of questions. Shereen, what do you think?
May I have a question, please?
Yeah, well, okay, go ahead, because you have opened your mic, but in principle, you are not expected to. Please go ahead.
Actually, I also mentioned it in the chat box. Anyway,
Sorry?
it's about the infection fatality ratio and the case fatality ratio in respect to COVID-19. What are the difference? What should we use? Thank you.
Yes. So if we are talking about, we are currently using the case fatality ratio. This is because it's the indicator, as I mentioned, it's knowing, it's easier to calculate it's easier for calculation, okay? And it is across different countries and across internationally recognized bodies. We can simply calculate the number, or divide the number of cases, the number of deaths, followed over by the total number of cases reported. And this is the one that has been agreed, okay, from the WHO about the case fatality ratio.
Okay, so Should we move to the next topics and then probably take a couple of minutes more for questions before the very end of the webinar?
So, sorry, Paula, shall I go on?
Yes, please. I was saying that we can take the final topics and then probably have a couple of minutes more for questions at the end of your few slides more.
Okay, sorry, just it was interrupted, sorry. Okay, so after conducting the analysis and identifying the descriptive epidemiology and the indicators, which indicators to be used and so on, here comes an important step, which is the final report, okay? Why do we report and this is really important for the decision-making facilitated. First of all, we give a summary of the situation, identify the actions that should be taken, and guide the decision makers in their response plans and actions. So what are the minimum data that should be included in the final report of the investigation? First of all, the title of the report, and of course this should be this should include the place and the date. Okay, these are two important criteria, okay, or variables that should be mentioned in the title of the report, and of course who is doing what in the where and when. Then comes to the background information, which is if related to the RRT, what prompted the investigation, why this team was deployed to City X during the period of time. That was because they have been notified of certain disease and so on, and okay, so the background information of is very important, followed by the aim of investigation and the methodology of the investigation, whether it has been just a field visit, the collection of samples and household survey or whatever, and then summary of the major findings, which is as my colleague Dr. Shireen has said, the basic epidemiology, the basic descriptive epidemiology is the triad of the person, place, and time, and then the indicators that are going to be used for quantifying or creating just such a baseline to measure the response plan over, and then the conclusion and the recommendations or the way forward after the investigation is finished. Okay, of course, these kind of reports could be periodic and could be updated, and maybe maybe also not just a final report of the investigation. There are what we call the CITRIP and the epidemiological bulletins, and the different kinds of reports are existing. However, it's important to always remember that we need to share information, okay? Because sharing accurate information is really matters in the decision making and allows for better planning and better response. Next, Paulo. So this is what we're talking about, the dissemination, and these are the examples of different tools. As we can see, there is the dashboard on the upper left side. There is the dashboard, the global dashboard for COVID-19, and there is from the lower left, there is the EWARN, Iraq disease surveillance bulletin, and there is also another report from one of the international NGOs, which is MSF, and so on. So these all are products, okay, that could be published on periodically or at different periods, and just to help to keep the decision makers and the public as well updated about the situation of the disease. Next, Paula. So now we are talking about an important issue that has been frequently addressed in different during the previous webinars, which is the ethical considerations and the principles of processing the data. If we are talking about, there is something called General Data Protection Rule, GDPR, which is about 99 articles. Okay, and the article number 5 has defined or identified seven principles for processing personal data. These 7 principles are about, the first one is about lawfulness, fairness, and transparency. Okay, being transparent in relation during that data collection process. And the second principle is the purpose limitation, which is the data that is collected should be used for its original purpose, and it should not be used for another purpose without the permission of the subjects. And there is also the third principle, which is about the data minimization. Keep the data that you are collected to a minimum level, and that's relevant to the conditions. So as there has been the case reporting form, there are a certain number of variables, okay, that we data about, and these are the ones identified, and so no more data should be collected other than those ones if you are talking about the COVID-19 case. Also, the accuracy, the personal data shall be accurate and should be kept updated. If we need, if for example, we are collecting context data, okay, then there should be a unique ID number, and then as the follow-up process is ongoing, then if some of these contacts develop symptoms, then it should be updated, and if not, okay, so it should be at the end of the follow-up period, it should be discarded. Also, there should be the fifth principle is about the storage limitation. Okay, so there should be the data should be stored to a certain period as agreed during the research or by the collecting body, but this is only for necessary purposes, and if it's not necessary to keep the data for a longer period, then it should be discarded after that period of time that's agreed with the collecting body. Also, there is an issue related to the confidentiality, and as we no one is allowed to disclose the information without the permission of the subject of interest, and data accessibility should be kept to those who are working with on the data management steps, either data entry or cleaning or analysis and interpretation, and of course also apart from the cleaning process, because there may be some duplicates, okay, but the data should be kept anonymous. Finally, the one or the person or the body collecting the data should be responsible about this data and how it's being used, and this is referred to as the accountability. Next slide. So we are talking about now about, it seems that the data management, as we have been talking about over the past 1.5 hours, that it's an easy process. However, we have always experiencing a lot of challenges during the data management. One of them is that the pre-existing data is insufficient, as we are, for example, if you are talking about the consensus data, okay, which is our secondary sources that we need to calculate rates such as the cause-specific death rate, or the prevalence, or the incidence, or the attack rate per 100,000 population. This should be updated. Also, another challenge is that discordant types and sources of potentially relevant data coming from different sources, and they are not matching. One of the major challenges that we are facing here in the regional office is that the authorities are mostly not ready to cooperate and publish real data, although this is important to guide the response. Another challenge is that conditions that can be changing more rapidly, as we are witnessing during the past few weeks, and there has been in different countries an upsurge of cases, okay, and the number of cases is really too much. So this may either affect the completeness or the quality of the data that has been reported. Sometimes there has been too much requests, okay, from the national focal points, from the ministers of health, to share some data that that has been identified to be important to calculate another new indicators that help to measure the situation and clearly assess, for example, the burden on the health system and the severity of the disease. So this is during the collection of different new numerators and denominators, or building new indicators. In such situation, there is a risk to overburden the system, and sometimes there is no response to such requests. And finally, one of the challenges is related to the political will, whether they are wanted to announce the real figures, okay, or not. Sometimes they want to keep the change. They want to report or communicate that there is no change, or sometimes they want to communicate that there is a little change, or some other bodies are willing to fully disclose the real situation. Next. So we now over for Silvio, I think.
Yes. So we have. Let me share first my screen. I'm going to do that. It's time for the evaluation of this webinar. So you can join at slido.com with the password eval, EVAL, or you can scan with your phone, and I'm going to open it right now. So I will have some time, so I think 5 minutes should be good.
So please stay with us till the end of the webinar. We will provide you with the link to join the Rapid Response Team Knowledge Network. Oui? Yes, please.
Paula? Yeah, can I step in? Can I step in?
Yes, very quickly.
Can I step in?
You can step in very quickly.
Yeah, very quickly. Okay. Yes, I will. Thank you very much. And thanks, colleague, for being with us. In fact, data management is a very hard work. Almost, I can tell you that 90% of the work in terms of analysis of data come from.
Thiebler, please, can you speak closer to your mic, please?
Yeah, hello. Can you hear me?
Very good.
Yes, yes.
Can you hear me now?
Very good.
Silvio?
Yes, please introduce
Can you hear me?
Yes, please introduce yourself.
Better? Okay, thank you very much. Now, right. Yeah.
Please go ahead.
Okay, thank you very much. I'm
Introduce
Chible Traore,
yourself.
working
Yeah.
for WHO African region. Currently, I'm in Democratic Republic of Congo, Equator, supporting the outbreak response for Ebola and COVID-19. Yes. In fact, the data management is kind of work which require patience and dedication. And it takes almost 90% of the work in terms of epidemiological analysis. The analysis part only take probably 5% of your time. So if a lot of work has been done to improve the quality of data, it will facilitate the life of everyone, even the decision makers. Thank you very much for being with us. Thanks.
Thanks very much, Dr. Tiebler, for your input and flagging a very important point on data management. So we can now get back to the evaluation. We thank you all in advance for letting us know what you think about the webinar. So you have a set of 5 questions to be responded to.
So we already have 68 people who will answer. So the first question is, did this webinar respond to key questions and challenges you encountered in the field? The second question is, please indicate to what extent you agree with the following statement. This webinar enabled me to learn something new thanks to the example and experiences shared by facilitators and participants. Okay, the third question is, please indicate to what extent you agree with the following statement. This webinar enabled me to consolidate my learning on how to manage and disseminate data in the context of the COVID-19 pandemic. The fourth question, please indicate to what extent you agree with the following statement. The methodologies and tools used during this webinar were good and facilitated my active participation. And the last one. And thank you all for answering the questions. So the last one is overall, how would you rate this webinar? We still have a few minutes for those who have time. I can see that right now we are 122 people connected to this webinar. Let's try to have at least 85 answers.
Yes, we still have 2 minutes, and then we can move to the final steps. Okay. Okay, not everybody responded to all the questions. This is what we can see, but at least we have more than 80 people who responded to the 4 initial questions, and we have to thank you all for doing so. Your feedback is very useful to us. Okay, we will now move to the next and final step for this webinar. Yes. So at the end of the presentation, you will see a series of resources that are proposed to you by our subject matter experts. You will see a mix of resources that include guidelines and training modules, and also intern guidance and websites. So feel free to go and explore those. Now, before we end up this series, as it was mentioned during the beginning of the presentation, there will be an evaluation of learning, and those who are interested in taking it can take it, of course. And this evaluation of learning will cover the 4 webinar topics that we have conducted so far. So the first one was active case finding and contact tracing. The second one was community engagement. The third, occupational health and safety. And now the 4th is data management and dissemination. So you have the link to access this evaluation of learning that will be sent to you all by email in the coming days. And there will be a time frame set for completing the evaluation, but it will be quite comfortable for you. And if it happens that you don't reach the 80% of correct answers, you will be given a chance to restart the evaluation again. So, and the other reminder is about the dates for the next webinars. This also will be confirmed to you very soon by email. So, and finally, you can see here in the last slide the link that enables you to join the Rapid Response Team Knowledge Network on MS Teams. So you can either scan the QR code or type the link that is provided here, and you will be able to join this community. And we definitely invite you to do so, because you will find there a number of interesting things to share with other people from various countries. So to end up with, we would like to thank you all for being with us today. It has been a very, very informative, very interesting presentation. So I want to thank also our colleagues, subject matter experts who design, develop the material and facilitate it today. So thanks to you all for your contributions, and of course thanks to the participants who were with us in high numbers. So if you wish, we can now take the time to open the mics and the videos to say goodbye and see the faces of everyone around.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Bye.
Bye-bye. Thank you.
Thank you. Bye.
Thank you.
Bye-bye from Myanmar.
Thank you.
See you next
Thank you
time.
very much. Thank you very much from Indonesia. Thank you. Thank you so much.
Namaste.
Thank you so much.
Namaste.
Thank you.
Namaste. Thank you so much. Bye.
From Bhutan.
Asante sana.
Asante
Gracias.
sana. Thank you.
Gracias.
Gracias. Grazie.
Thank you. Bye-bye, Rafik from Mozambique.
Okay, thank you.
Nice from Madam Kinga from Bhutan.
Merci, Bhutan. Okay. Okay. So thanks a lot. I'm now going to end up the meeting. Hope to see you in the next webinars in November. Philippe, any final word?
Thanks to everybody for your participation and to the colleagues who organized and prepared for this session. Thanks very much. Great.
Okay, bye-bye. Thank you.
Bye-bye.